So I'll briefly then start with some landscape about where neurosurgery is and where the AI application is in neurosurgery. And then we'll move on to some examples of various AI models that is currently in research, or some of them that are already in practice. And then we'll move on to some challenges of implementing these AI models in neurosurgery and clinical practice in general. And then we'll also talk about the ethical concerns that's been raised, as well as what is coming in the future and what it'll impact in our neurosurgical practice. I do not have any disclosures, so this is something that I wanted to introduce with is a neurosurgical landscape. So we've seen and we utilize a lot of instruments and technology nowadays in our operating theater, and the complexity of how we do it is increasing day by day. There is a lot of tools, a lot of data being generated during surgery, even before we start operating on patients. And you've got imaging, very high advanced imaging with a lot of data from imaging, as well as the demand of precision is increasing every day as we utilize these various complex techniques. But in terms of being human, we have a limited capacity of analyzing all this data together in one and the interpretation part. So that is where AI comes in to provide an augmentation of these high dimensional data that comes out of our operating theaters. And this is an example video of what we normally do in King's, which has been published recently about tubular retractor surgery, where we are operating at the depth for a glioma using multiple, technologies, navigation systems, DTI techniques, fluorescence technology, and lots of other things in intraoperative neuromonitoring. So there's a lot of data coming out of these technologies that we can rightly use to provide assistance for us to increase the precision of what we do as neurosurgeons. So we'll briefly talk about where the application began in neurosurgery. So although the technology came into light and became hyped recently in the last few years, but the application goes back beyond 50 years in neurosurgery. So early in 1970s and 1980s, it began by some very simple diagnostic support and clinical decision making, as well as the start of first robot-assisted brain biopsy in 1985. So that kicked off the use of very early AI technology, which then moved on from there to 1990s and the 2000s, where we saw a rise of a lot of technology, especially with computer-assisted navigation techniques, as well as microsurgical robotics. There was a lot of softwares that came out for surgical planning as well as neuronavigation in the 1990s, where the early application of these AI models was already there in our practice. There was some outcome prediction technologies, image analysis techniques, which were very in a very early stage, and they were not very accurate at the beginning. Similarly, the start of neurosurgical robots like the CyberKnife 30 years ago, as well as the Neuromate robot that started in 1989, that kicked off more of application part of these advanced planning softwares, as well as use of robotics, which already had some degree of artificial intelligence models applied in the background. Since then, in 2010 to 2020s, in the last decade, we have seen an outburst of deep learning techniques that has been embedded in our preoperative planning softwares, surgical precision techniques, as well as new technologies of image recognition, use of tumor detection softwares, and segmentation techniques that has become very accurate as compared to earlier decades. In the last few years, we have now seen the use of natural language processing and large language models and reading text-related data and producing text-related outputs. And that has then also helped a lot in terms of building up onto new surgical training modules, as well as use of automated tasks like the use of agentic AI in specifically with the text-related models. This then has now opened a big Pandora's box of multimodal artificial intelligence, where you can input lots of different data that may include text-related data that comes out of your electronic health records, or genomic data that comes out from your sequencing that you do for the tumor tissue that you perform during surgery, as well as the clinical data that can be input. And that has all been combined together into multimodal techniques. And there's a lot of new models that are coming out that can ingest a lot of this data together rather than having models separately for separate things. And especially in the last few years, there has been a lot of talk about explainable AI outputs to understand exactly where the outputs are coming from and how is the AI really picking up these information from and where the predictions are coming from. So we'll talk about a few things in terms of where it's been applied. So the preoperative planning as well as intraoperative techniques, navigation, robotics. I'll give you some examples. There's a lot of things that is there, so I've only selected few in the slides. So we'll talk about some outcome prediction models as well as some post-operative models. And there will be some focus on neuro-oncology, as my PhD is on that part. But I'll talk about all the various subspecialties of neurosurgery, and also a big talk on ethical concerns and why we haven't been able to implement everything directly into clinical practice and how far we are in terms of that being applied to. So in terms of introducing the topic, so we've seen how traditional surgical decision making is made by using the knowledge about the experience that the surgeon has, as well as the knowledge that comes from anatomy, and that combined together with judgment is actually how the surgical decision making is done. And nowadays there is a move from a person making a decision versus a multidisciplinary team deciding together and getting input from other specialties also to provide best for the patients. So that's where the AI application now feeds into all of these modalities, where it can augment various types of data that comes into our clinical practice and our surgical workflow. It might be imaging, it might be genetics, it might be connectomic data that comes out from the detailed analysis of the tracts within the brain. And some of the examples that we've seen commonly that has been published is tumor segmentation, where you can accurately now segment the various parts of the tumor, the enhancing core or the flare part of the tumor, as well as use of deep learning AI models in tractography, where you can now accurately predict or give an idea about where the tracts are from the MRI images itself. This is an example in the slide. You can see where there are various kinds of data that we can ingest in our neurosurgical practice. Especially here in the slide, we focus on high-grade glioma, where you can see there is data coming out from conventional MRI images that we do normally in preoperatively. There are other advanced imaging that we might do, for example, PET scans or SPECT scans that we utilize depending on the diagnosis. And there are some functional imaging that we do for tumor surgeries, for example, in eloquent brain tumors. And these techniques provide a lot of input from imaging side. But there are other data that is a big chunk of data that comes out from analyzing these tumor tissues that we resect, and we get the RNA-related sequencing data, DNA data for mutations, genetic alterations, or methylation data that comes out from that. And further downstream, there is proteomic data, the proteins that are generated from these RNA, as well as metabolomics data that can be utilized to feed into these AI models to provide us prediction models or diagnostic models. There is a large data of histopathological neurohistopathology that comes into play also, and there is a very big data set that is now available with a high resolution that you can get that information combined together with multiple images, so building up to a multimodal AI, which is the future of any AI models, especially in neurosurgery, where we can ingest a lot of information coming out from the patient and inform correctly utilizing these different data sets. If you look at the workflow of how a tumor surgery occurs, and we are all aware of this workflow, starting with the diagnostic imaging and then moving on to the adjuvant treatment. And there are various areas where these AI models can be applied to provide various types of diagnostic or prognostic information. So if you look at the diagnostic side of things in the early stage where you perform the MRI images, it can provide information about prediction about molecular classifications, IDH mutation, or grading of the tumor, or even identifying what type of tumor it is at the earliest stage, even before they're ready. Or is it a metastasis, or it's something more related to abscess, or how we can identify. There are models that now currently under research, and a lot of models are now giving us a good accuracy in terms of predicting different types of tumors, different grades of tumors, and that can further be utilized for recurrence prediction or longitudinal monitoring and identifying when the tumor would recur, or even survival prediction, overall survival or progression-free survival for tumors. Moving on to the other part where it can be applied is surgical planning and prediction of extent of resection within surgery itself. So the models are being built currently under research, which can provide you an idea about how much resection you've done based on the MRI and based on the resection within the intraoperative field itself, analyzing the real-time videos of your operating microscope, that you can get an idea about extent of resection. There are models now being built in research for invasive zone mapping. So if it's a high-grade glioma, how much to resect and where to go to, and whether that's a malignant tumor or it's a normal tissue. So that also is under research and is getting better every day in terms of predicting these zones, and they can help a lot in terms of our surgical techniques. There is, if you move on to the intraoperative, there's real-time imaging augmentation, there's real-time feedback about what molecular characteristics the tumor might have, and what kind of fluorescence predictions can be made during surgery that can guide us during our resection strategies. Similarly, post-operatively, there are various models being built in, especially for radiotherapy planning, as well as trying to accurately provide normal tissue sparing with the various radiotherapy planning softwares. And there are AI models now being implemented into that part where you can accurately give us an idea about the zones where the radiotherapy can be applied. Similarly, with chemotherapy, sensitivity prediction early on for a particular type of tumors, or response monitoring and identifying pseudoprogression versus true progression. So there are various AI models also being built in that part of the workflow. Similarly, at the end of that workflow is immunotherapy, where my current PhD is working on. I'm trying to predict the tumor microenvironment on the immune system within the tumor itself from the diagnostic imaging, to try and stratify patients to see which patients would benefit from, for example, neoadjuvant immunotherapy early on, and which would be responders versus which might be non-responders for these kind of immunotherapy. So that's something I'm working on in my PhD, and some of the models will be published soon. So what AI really means in neurosurgery, there you'll be hearing a lot of these terms in any talks related to AI in neurosurgery. So they'll be talking, there's words like machine learning, deep learning, large language models. The basic idea, what we need to understand is the whole thing about artificial intelligence is an umbrella term, and that has multiple different sections within them. And machine learning is a big part within artificial intelligence, where current models and the last decade of work has been done. And deep learning is a part of machine learning, where an advanced or models are being built. And the large language models that we keep on seeing, like ChatGPT, or these are even a further section within deep learning, a part of deep learning that work on the text input and multimodality input. And there are various kinds of data that these models use. There's structured data versus unstructured data. Within that, there's multiple data sets that we talked about in the previous slides about imaging, various types of image-related data, and there is neuropathology data that comes in, electronic health records, text-related data, and genomic data. And you'll be hearing a lot about supervised versus unsupervised learning. Supervised learning simply means you're providing all the information to the AI model during its training process so that it's all supervised by human input. Unsupervised learning is something that the AI model learns on its own without providing additional input. So for example, if you're giving an image to an AI model and you're not providing any other information about the image, whether it's a normal scan or it's an abnormal scan, and the AI model automatically understands that there is a lesion in the image, that means that is unsupervised learning. Whereas supervised learning is something that you provide input for all the stages. You say that this is an abnormal scan, this is a normal scan, this is a glioma versus this is a meningioma, and that's how the models learn. And ultimately, they provide various predictions. Either it's an anomaly detection model or it's a triage model that can give you an idea about which is aggressive versus which is a benign tumor, and classifications of these models, these tumors. So this is a very good example of how and which kind of applications have been done in medicine by AI, and that applies a lot to neurosurgery also. And this is a good review article published in Nature in 2019 by Eric Topol. And you can see that there has been applications in various parts of specialities. And if you look at neurosurgery itself and neuroimaging, you can see that it's been highlighted that there is a lot of use of AI has been done in acute neurological events, bleeds, hemorrhages, or head traumas. There has been applications also in brain tumors, looking at methylation or metastases. And if you look at this table now, these are FDA approvals of these AI models that are currently in use in the United States, where it has been used to either predict or diagnose brain bleeds or hemorrhages early on, or interpretation of the MRI brain scans, CT stroke diagnosis, or hemorrhages again. And this workflow summarizes in a lot of applications that can be done early on, in the stage of when the baby is born. Even in fetal neurosurgical techniques, you can apply these models all the way down to predicting prognosis, how long the patient will survive, as well as trying to prevent any complications during surgery. And there is a lot of data that can be input into an AI model. The idea of giving more data is to avoid bias. If we give only a certain information and not give all the information, the models will be biased in giving an output. And usually when an AI model is developed, you have to validate that in silico in an external data set, and then apply that in your local data on a real world data set. And ultimately that can then be implemented in healthcare. And there is a lot of approvals that needs to be taken before it actually gets implemented in the clinical practice. Now, there was a question about whether these AI models will take over our jobs, whether we will be we won't be performing any surgery in the future, but it doesn't look like. It looks like that from the same article that what will happen in the future is there will be a synergy between the AI models and the surgeons. So what will happen is surgeons are best in operating, and that will remain with the surgeons, and AI will deal with the rest of the functions that the machines can do better, and leave the part that humans can do better to humans or surgeons. So we're looking at something like partial automation or conditional automation for these AI models to be implemented in medicine, and especially and also in neurosurgery. It's unlikely that we will go into full automation or even high automation. So that brings on to a very nice conclusion of how the AI partnership would be with neurosurgeons is AI will always act as a co-pilot, and neurosurgeons will always retain the command. And you can see that parallel to what we can see in aviation, where there is an autopilot function which improves the safety, but it does not provide any skills, which remains with the pilot, and is same that will happen or is happening with the neurosurgeons also. We will get some extra time for cognitive unburdening, and then we'll have time for empathy and teaching and producing, being more creative with our surgical techniques, and that's how it will play out in the future. This is a good paper now summarizing lots of models and comparisons between these models and what are the ethical implications. This is a recent systematic review published in 2025 that looks at various papers that's been published in the literature and what type of models and what are the different predictions they are doing. So there are models that are looking at predicting things from spine, brain, as well as trying to see if it's a diagnostic model or whether it's an analytical model or it's a prognostic model. So there are various things that these models have been devised. And if you look at the limitations, so there is and highlight that there is still a lot of bias in these models. There is issue with data set sizes, issue with difficulty in integration, and issue with the explainability, and we're not sure from where the models are picking up the information, and transparency, as well as small sample size. So there is a promise of enhancing diagnostic accuracy in the future, but there's still a lot of ethical challenges, as well as there has been some efforts in terms of to make the AI more explainable to us so that we can rely on them easily. So then we'll move on to these different areas of use case scenarios where the research is happening and where things are moving forward. And we can clearly see from the graph in the corner that there has been a spike in research related to AI in neurosurgery in various specialties, most of them in neuro-oncology, vascular, spine, neurotrauma, and functional. So there's a very big spike of research in various specialties of neurosurgery where the applications are numerous in each particular specialty, depending on what type of things you're doing. It could be related to gliomas, or it could be related to spine surgeries, predicting prognosis, or even epilepsy surgeries, so trying to predict outcomes in complicated neurosurgical resections for epilepsy surgeries, as well as in vascular cases where you're detecting vascular lesions, aneurysms, and identifying the prognosis or when the aneurysm would rupture, what is the risks for AVMs. Similarly, in functional neurosurgery, there is a big explosion in research happening in brain-computer interface and spinal cord implants, where AI is being now implemented. And currently, there is a clinical trial running using this brain-computer interface with AI models. So we start with some examples from stroke and skull base. So this is an example on the top with a recent publication in 2025 from in the radiology artificial intelligence, where the images, the MRI images, are utilized to predict the prognosis of stroke patients, and identifying the stroke early on and predicting prognosis seems to be a big area of research in stroke related models. Similarly, if we look at the bottom in skull base, this is an example of chordoma patients where the AI models are able to give you a prediction about the genetic signatures as well as clinical outcomes and how these patients would behave in the future early on at the time of diagnosis, so that then you can decide and select patients appropriately for surgery as well as other adjuvant treatments. This is a good example in pediatric neurosurgery, was published recently in New England Journal of Medicine, where we can see that these AI models were trained in pediatric glioma patients in a longitudinal way, where various stages of images were used in follow-ups, and these images were trained in the AI model that can then now provide predictions about when the tumor would recur and early recurrence detections, as well as helping in point of care decision support. So that's and also the result of this early application was that it was able to provide an improved prediction of 1 year recurrence in these pediatric gliomas, and it can be a big help in terms of identifying these cases so that you can go in early and provide treatment, including surgery if required. In neuro-oncology also, there has been quite a bit of publications now in research about various models. And this is an example of an AI-guided virtual biopsy. That means you are able to classify these tumors early on, even without needing a biopsy or going through surgery. So, this is an example of paper where deep learning technology was utilized, and we're able to distinguish between malignant versus benign tumor from MRI. You could tell with good accuracy if it's an inflammatory lesion or if it's a glioma or there is an ICH, hemorrhage in the tumor, or it's a meningioma or metastasis. Similarly, in neuropathology, also there has been a lot of work that's been ongoing in identifying and reporting these pathological slides where the AI models, you can have a conversation now. This is an example of a model called PathChat-2 released by in Boston from Harvard that has a large language model where you can communicate with the model regarding the pathology slides, and you can then accurately provide diagnosis, locate these areas within the pathology slides, and use this to train these AI models to accurately provide predictions as well as drug response, and depending on what type of lesions they are. Similarly, we published some research in early application of these machine learning models in transcranial magnetic stimulation related models, where we were able to provide an idea about tumor grade just from the data that we obtained by doing a TMS, or transcranial magnetic stimulation, in motor eloquent gliomas that provided a lot of information early on before tackling these gliomas during surgery. And these at the bottom are softwares and research that can accurately now automatically segment these gliomas and glioblastomas, where you can have idea about various areas within the tumor itself, necrotic core, or it's an enhancing area, or it's a flare related enhancing regions of these tumors. And it's all automatic now, and these are coming up more and more, where automatic segmentation is becoming more accurate compared to last few years, where there was a lot of work in manual segmentation, where surgeons would just sit down, or the radiologists would sit down and do the segmentations for hours and hours. And that brings on to neuroimaging. So there is a lot of work in neuroimaging regarding these AI models, and that are helping surgeons also, as well as providing a lot of help to the neuroradiologists. So this is an example of a paper published in Radiology Artificial Intelligence, where you can predict IDH mutation from an MRI, a preoperative MRI. And then that can influence a lot of things in terms of how to proceed with surgery, what adjuvant treatments to provide, as well as even new adjuvant therapies. And at the bottom, this is an application part of things. So this is called Viz AI models, that softwares that are currently in use in this United States, where there is a platform where all these specialties, including radiologists, surgeons, get flagged as soon as the scan is performed, and you will get an idea what the diagnosis is in a text message within the software. There is a possibility there is a bleed, there is a possibility there is an aneurysm in the scan, and the surgeons as well as the radiologists are flagged early on, and you can collaborate with the entire care team in real time while the AI is analyzing the models, analyzing the images. So this is something that's already been implemented, and that's coming in the rest of the world, I suppose. Moving on to the other part, we'll talk about spine, where AI has been able to provide post-operative outcome predictions, or be able to detect inadvertent durotomies during surgery, where you miss them and then there is a CSF leak afterwards. So this is natural language processing models that can be used within theaters, and also an AI that provide prognosis to patients with spinal cord injury. So these are two examples I put forward. There's lots of examples, but these are two things that this one is in an AI model that can automatically segment the intramedullary lesions within the spinal cord when the patient has a spinal cord injury, and be able to give us an idea about prognosis and accurately identify how big is the injury, where is the injury, and how to tackle these. So similarly, in the other half is related to degenerative spine, where there's algorithms that can now predict and identify coracoid compressions in degenerative lumbar disease, and also give an idea about how early they can deteriorate, or what will be the best time to operate, whether they are and provide some prognostic information, and how big is the disc and things like that. So that's something that's also in research and active research, and is coming in application stage. In terms of robotics, this is something that we are currently using in King's for training purposes only for now. And there is current fellows in spine surgery being trained in using these robotic systems. And this is an example called Measure Robotics, a guidance system for Medtronic that we are using in King's in our simulation labs, where the surgeons are being trained to use these guiding systems, which can provide you an idea about pre-op analytics, give you an idea about intraoperative navigation, and accurately identifying these locations. So this is an example where this robotic guiding system can give you an idea about where the screws will go in, and what is the right location for putting in the screws, as well as what's the depth, how far you're going in, and providing real-time feedback in putting these screws in. And this has been quite useful for training purposes of surgeons that are training to become spine surgeons, or who are getting that specialty training, and it's been useful, quite useful for training also. And it is likely that this will be implemented in intraoperative settings as well. Then we move on to epilepsy in epilepsy surgery, so where AI can help in producing predictions of surgical outcomes in epilepsy cases. So this is an example of a prediction model that utilizes AI and utilizes the EEG readings, and that can come from both ictal and interictal recordings, and they can then provide accurate predictions of these areas of seizure locations. It can input both intracranial as well as stereotactic EEG, and during surgery, as well as even pre-operatively, it can provide information about seizure onset location and localization, and if you're missing anything during surgery also. And these are models that are currently being in active research. And these are something that is coming out soon. And there are models that now can provide even early seizure predictions for these patients, when the next seizure is happening, or how you can avoid that. If we move on to vascular lesions, so there are models now in research that can provide you an idea about detecting brain aneurysm rupture. So this is a prediction model that was published in Journal of Neurosurgery recently in May, where the models were able to identify the size of the morphology of the brain aneurysm, and then give an idea about what is the risk of rupture of these aneurysms. And this gives a lot of information early on. As soon as the scan happens in the multidisciplinary meetings, you can discuss this, and get an idea about what is the risk of prediction of risk of these ruptures of these aneurysms. And you can then utilize this information for educating the patient, giving early information, and also deciding which aneurysms requires early treatment versus which can be imaged regularly. The next one we'll talk about is functional. A lot of a summary slide as such in brain-computer interface. There is a lot of work nowadays being looked at the signal processing from the chips that's been implanted, starting from controlling the cursors, auditory sensations in patients with cortical implants or cochlear implants, as well as devices that can produce spellings or words from signals coming out from the brain chip implants, as well as providing limb control for patients who have lost their limbs, and visual processes. So there is currently a trial going on from Neuralink, you might have heard, where it's been implanted on spinal cord injury patients and trying to see if they can give an input for early mobilization of these patients also. So now we move into a slightly different application stage where we look at preoperative, intraoperative, as well as postoperative application of these AI models. And these can be applied in all these settings in different scenarios and providing a richness of different information that we require. So it could be related to segmentations early on preoperatively, or diagnostic dilemmas that can be solved easily, risk predictions, and even patient selection. For example, clinical trials where you want to provide a new adjuvant therapy before going for surgery. So that's something that can be applied for these, as well as intraoperatively. We talked a lot about the robotics in spine surgery, as well as navigation and real-time decision support. And we'll go through some of the further examples of how this has been applied both in intraoperative and postoperatively. This was a recent scoping review that was published in World Neurosurgery, which basically summarized where the application is in preoperative planning. So the main thing here is in main three specialties: functional, spine, and oncology, where this has been applied. And the main application here is automatic processing of clinical and imaging information, individualized selection of surgical approaches depending on the type of lesion and what type of patient we are getting, as well as data-driven decision making. So these are where the applications are moving in preoperative planning. If we look at intraoperative planning and navigation, this is something that we normally use in King's. So this is a normal setup for our glioma surgeries, where we utilize a lot of data coming out from multiple instruments, as I mentioned initially. So there is neuronavigation intraoperatively, as well as tractography that we use, as well as segmentations of the tumor and early on that we can then highlight on the patient itself, and that can help a lot during resection. And a lot of richness of information coming out from intraoperative navigation and neuromonitoring. So that is currently what we're doing. Next stage where things are moving is, this is an example of a research-based AI model that can basically generate synthetic CT scans from MRI images. So you don't need to now expose patients to radiation, and you can get a synthetic CT from MRI itself that can be then further utilized downstream for preoperative planning, as well as neuronavigation, and even for radiotherapy planning. So this is something that's coming in the future in that section of preoperative, as well as radiotherapy planning. In terms of training, so we have seen quite a few models that have come out that now provide information for training purposes for new surgeons that are coming in. So this is an example at the bottom of a endoscopic pituitary surgery in the nasal cavity, where the AI model automatically gives you an idea and segments those areas and gives you a highlight of those areas where you need to focus on when the person is training for these operative procedure. And this can be done in simulation settings. It doesn't have to be in the patient itself. So you can utilize a video from a previous patient, use these models to train in a simulation setting for navigating around these nasal cavities and locating these high-risk areas. For example, you can see where the sella is, and clavicular recess. You can even identify the carotids and give you an idea where the carotids are, so you can avoid these areas during training. And that can help a lot of surgeons which are early years of training in neurosurgery. And this is an example now that I'll be talking about electronic health records, which we are currently utilizing at King's. And there is a model that we are using called CogStack, which can basically read your clinical text input that you're providing in your electronic health record and give you a prediction of what's coming in the future. When is the next appointment going to be? Or what is this patient likely to have in the future? What is the complication this patient might have? Or what are procedures this patient might require in the future? So this is something that we are currently trialing at King's. It's been developed within King's itself with help with the partner hospitals in London. And we are using this for information retrieval, extraction, and as a natural language processing platform. So this is already in use within our electronic health record that can pull information from there and then provide you with various predictions. I mentioned a few things about operating theatre, and I'll give you a few more examples about what's been done in operating theatre itself, providing real-time information for precision and analyzing these videos within surgery, as well as how they can help in training of future neurosurgeons. These two examples here are papers published in Nature, where you can see the top one is a multimodal foundation model that utilizes information coming in from the Raman histology that is done intraoperatively and utilizes the preoperative MRI and gives you an idea about infiltration detection during surgery itself. And if you, for example, you're doing a resection, you provide the tissue that you resected to the machine, it will give you a prediction whether you have the tissue has tumor in it or you already crossed the resection margin, where you can then stop reliably during surgery. The bottom example is an example of a deep learning based classification tumor model that can provide you with an idea about what the tumor histology is, or what is the tumor diagnosis likely going to be using nanopore sequencing, and that can provide information within 80 minutes of you providing the tissue. So within an hour, mainly to get that information during surgery when you're doing a 4-hour long surgery. So it's a good idea to get that information early on about the diagnosis of the tumor and where to proceed with resection. So this is something that's been published recently, and it's in the early pilot phase of application in intraoperative setting. I did mention about training. So this is an example of AI model that's been published in Digital Medicine recently from colleagues in London itself, where they trained an AI model to learn about endoscopic pituitary surgery. And this is the model that basically gives you an idea about segmentation of these regions reliably and that can be utilized early on in training. And this is an image where you can see that the ground truth, which is the actual location of these areas, and the heat map of AI prediction that is quite close together, and they're quite reliable in predicting these areas, even when the ground truth is not provided. I did mention briefly about the neuroprosthesis, and this is something that's published recently last year in New England Journal of Medicine, where AI has been used in post-operative context, where patient has already undergone surgery, has some damage in the speech generation areas, and these implants can be utilized. Or if it's a patient with traumatic brain injury, then these brain implants or brain-computer interfaces can provide the models that has been trained to give you and predict the next word that the patient is trying to say, and more accurately trying to predict both language as well as words in highest probability sequence. So not just words. Now the patient can be able to speak the whole sentence, and the accuracy is quite good in these models. And this is also in pilot phase of being trialed in coming out in clinical practice. So in summary, these models are both providing a lot of information about prediction as well as precision, and in outcome prediction, as well as personalized risk stratification and selecting patients. And there is a lot of talk nowadays about this new upcoming topic called digital twins in neurosurgery. This basically means that you have a virtual simulation of a patient's brain with the condition that you can train or that you can then dissect virtually, or if you're doing a surgery before you go into the actual patient. So this is quite useful, that can basically replicate what a patient has into a digital format, and then you can then train on those, and apply in simulation what kind of treatment you're going to give, what will be the outcome of that treatment, whether it's surgery, whether it's resection, whether it's biopsy. So that is an upcoming research that's going on in neurosurgery, in AI, is what that's called digital twin. So you're basically creating a digital twin of that particular patient from imaging and from the rest of the data, and then you can then simulate that in simulation setting. So ultimately, the clinical outcome impact from these models will be improved diagnostic accuracy, enhanced precision, reduced complications, as well as we'll have quantifying metrics that we can then reliably apply in regular practices. But talking about that, there is a lot of challenges in implementing these in the actual practice. The main four big challenges that I have highlighted here is, the first one is the algorithmic bias and generalizability. So that is a big hurdle for these AI models that is currently being a big issue, where they can't be applied directly into clinical practice because they might be trained on a very small number of data sets, or the data is only coming out from a certain center and it's not from multi-center studies. So they cannot generalize to other populations or other group of patients. Similarly, there is a lot of problems with infrastructure and research gaps in different parts of the world. And it's not, there are centers where they have all the infrastructure where they can train AI models, but there are centers where they have limited capacity of training or using these AI models also. And applying AI models in clinical practice, you require a lot of hardware also. It's not just copying it from the internet, but then you'll have to have some hardware inbuilt into your hospital setting. Then only you can actually apply these current AI models. So there is a resource gap. Similarly, there is a lot of work that needs to be done in regulatory as well as ethical uncertainty for these AI models, because of the bias that's existing in where the data has come and what type of data is being used to train these models. Because ultimately, the model will behave in a way, and it will copy or it'll learn from that same data that it's been trained on. So if it's a wrong data, or if it's a biased data that the model is being trained on, then the results will also be biased. So that's something that needs to be worked on. And there has to be a lot of training for workforce which are not used to using these AI models, for integration and acceptance. There is quite a few papers that I've listed here that has been published recently that is looking at how this has been worked on and what are the concerns that's been raised. And this is an example that was published just like in this month, in last few days, that looked at what are the issues of validation of these surgical tools, and that can be also applied in neurosurgery. So there are highlighted points about where could be the pitfalls in validation, and then what are the potential consequences if those pitfalls are applied, and ultimately what are the real world risks that can come out if these are applied without the regulatory mechanisms. So you can see some examples here. There is, examples about data imbalance, poor quality of the data, limitations about individual metrics, and there's insufficient reporting, and that can go into various consequences like failure modes or leakage of data, and suboptimal resource use, introduction of bias into the models. And what can they do in real world scenarios is they can overestimate certain predictions, or they can provide unfairness to certain group of patients, or there could be poor generalization of these models in real world applications. And that can then lead to loss of trust, stagnation of research progress, rejections of delays, risk of investments, and ultimately they can impact on the patients and the benefit that the patient might not get if these are not actually dealt with in the before these are applied. So these are something that's been highlighted in this paper, where what are the pitfalls and how they can be tackled, or what are the consequences that can happen if they are not applied or dealt with appropriately early on. And so I wanted to touch upon this part also, which is the neurosurgical data and ethics. So there is a lot of things that we ignore in our daily practice as neurosurgeons, and there's a lot of data that can help and these AI models in training, as well as if the AI models are not exposed to these data, then there can be a lot of bias introduced into these AI models. So that data, this is an image that I took from the World Health Organization publication here. There are two publications I put up here is the Ethics and Governance of Artificial Intelligence for Health by WHO, and Ethics and Governance of Artificial Intelligence, a second version published by WHO recently. And these highlights all of these data, and we are focusing on a lot of things like clinical trials, genomics, omics, clinical records, laboratory results, electronic health records. But there are some of the other things that we're completely ignoring in research, lifestyle, socioeconomic, behavioral, and so these can impact a lot in the biases that are introduced within the AI models and how they can be transparently used. So that is also another issue in terms of using this data and consenting these data early on before using it for training. And these are the concerns raised by patients that's been captured in this wheel. So who will be using my data? Will I be asked for consent? Could my data be sold? These are various real-time concerns raised. And can I see and correct the data about me? Will my data be anonymous? Is my data secure? What will my data be used for? And what are the benefits that comes out from this data? So these are very common questions raised by patients in terms of where the data is going into. And there is a few research publications that I've listed here in terms of medical ethics, and especially in concerns raised in neurosurgery. This is a nice systematic review. It might be difficult to read all the details, but I would suggest people to read these from these journals that's published recently in 2025 about ethical concerns and what were the key findings. And there were concerns about application, concerns about emphasis of understanding the AI, what are the black box of this AI, and what are the information that is pulling out from. And there's a lot of highlights about weaknesses of these AI models. And there's a lack of factual information, lack of creative text formats. This is especially for those large language models. There has been some work that now is coming out about how we can make an ethical framework for these neurosurgical AI models. And there has been some work about how we can then ethically build these frameworks before they are applied into the clinical practice. This is very early on, and there needs to be a lot of more work in these ethical frameworks in the future before it's applied in the clinical practice. But there is some thinking already on in terms of building a framework before they come into our practice. So now we come towards the end of the talk about what are the future trends and what's next coming up for neurosurgery and AI. So there is a lot of talk about collaborative AI in between various institutions, and that is the only way we can tackle a lot of bias that comes in depending on the population and the type of patients and that we see in different areas of the world. Federated learning is something that is coming up, which means that you do not share your data with anybody else, but the model can learn in a larger scale between various institutions without the data being submitted to other parts of the country, or the data leakage is completely avoided, and that can be stored in your local center without this being going into other centers, and still the AI models can learn. So that is the term called federated learning. Similarly, explainable and transparent AI is something that needs to be done in the future, and there's a lot of talk about it now, where you can then identify actually where the AI is learning from. So if it's an image, so what part of the image is the AI learning from? And we can see that early on. That means that'll help us grow confidence on these AI models before we apply to these patients. I mentioned about multimodal and integrated models, where you can ingest a lot of different data sets, not just imaging or genomics, but combining all of these data. And there is a lot of work on generative AI and data synthesis. So if there is a lack of data, for example, some rare patients, that you will not be able to get a lot of data anyway. So there is work on models that can generate synthetic data and that can help train these models and then pick up these rare scenarios or rare cases that we don't see normally in our daily practice, and that can help identify these patients early on. And there is, as I mentioned earlier, about robotics as well as brain-computer interfaces, and clinical trials now are already in place for these various models. So this is a summary of a future direction that I put in. This cycle here is a deep learning healthcare system cycle where the AI can, how AI can work together with surgeons, with various other specialties in hospital, where, you have harmonization or pre-processing of these data. There is some analysis that the AI model produces that can help in diagnosis and treatment selection. And then it provides some recommendations. And then we do a multidisciplinary meeting. We identify what is the best route with surgeons and all the specialties being in the team, and then we provide that clinical decision. But that's all solely based on the humans still, from based on the surgeons, based on oncologists, based on the multidisciplinary team. And ultimately, that data can then again be input into the knowledge base, which then the AI will again utilize in a circular kind of training, regularly training these AI models is the next step, where they can then learn about new things and then avoid more errors in the future. This is a slide that I specifically prepared for low resource limited settings where they can be utilized. So AI models in neurosurgery, what could be the clinical challenge? So there are challenges where you can't have subspecialty imaging, or there's a lack of imaging facilities. Then you can have, AI-assisted interpretation and provide general radiologists or non-specialists in rural or district hospitals about these diagnoses, and they can triage this patient early on to specialist centers. Similarly, avoid delays in diagnosis for trauma or brain tumors, where you can use rapid triage related AI models. For CT scans also, where you can give the time, to reduce the time to diagnosis and delays in referrals to in emergency settings. Similarly, if there is a shortage of neurosurgical expertise, it can help in decision support, where you can provide support to non-specialist clinicians in the referral centers with some recommendations about what you should do before these patients are being seen by neurosurgeons or specialists. Similarly, for follow-up as well as monitoring, if you're discharging a patient to a remote location, then there is models that can provide you prognostic information or mobile-based monitoring tools in remote areas where the patient can be followed up or remotely, and you can access that information in the hospital about their follow-up information, wound breakdown, CSF leaks early on, and then you can triage these patients or ask them to come to the hospital early on. So these are some of the applications that can be done in resource limited settings with models that do not require a lot of hardware, or that can be applied within your mobile-based technologies itself. So what's the how we should behave, or how things should go forward in the future? This is my personal opinion from these data that I have looked at, is there should be multidisciplinary teams, not just single surgeons or clinicians working, but you should have a data scientist, engineers, and ethicists within your team that can appropriately look at these AI models in the future, and then that will help in implementing them in a smooth manner as well as in an informed manner. And we should demand, whenever we are looking at AI tools, that we should demand for clinically validated AI tools, and those tools that can provide us explainable information about how these AI tools are providing predictions, and also embrace what's coming, because this is something that we can't really avoid, and AI tools will be there in your clinical practice. So we should be embracing open science rather than closed science, only open access models, and global collaboration is the key for applying these models appropriately in clinical settings in the future. So in conclusion, what I would say is the next era for neurosurgery is data-driven, precise, and patient-tailored neurosurgery, with AI as augmentation rather than any autonomy to them. And as surgeons, we will be there making that decision, but AI will be the one that is providing information as a co-pilot with continuous improvement that undergoes in the background. And thank you for listening. So if there's any questions, I will take any
Thank you,
questions. Yeah.
Professor Ghimire. It was an absolute pleasure to listen to you. Thank you for a spectacular presentation. You covered all the grounds, and all the questions I had in my mind prepared were answered throughout the lecture. So I thank you. And I think the audience saw it's no longer the science fiction, rather it's our reality. It is here. AI is
Yeah.
not going anywhere, and rather than being scared of becoming obsolete and being replaced, but we should be in awe and hold some kind of reverence that together it can be tremendous to see it for what it is. In truth, it is a tremendous tool that can help the humanity to make the next leap, and especially in neurosurgery it's a tremendous tool. You mentioned starting from prenatal diagnostic, intraoperative help, and even post-surgically in the follow-up to determine and predict the something that it's humanly we were not capable until AI. So thank you for opening eyes of many in the audience and bringing this reality in such a humble and beautiful way. Thank you once again.
It's my pleasure.
I
It's my pleasure. Thank you for giving me this opportunity.
Madonna,
She might be frozen.
connection problems.
Yeah.
Okay. I think one of the audience wants to talk.
Yeah, absolutely. Happy to have any questions.
Okay, Lauren.
see raised hand, Lauren Ture.
Yeah,
Yes. Mhm.
Madonna, you was frozen.
Oh, I was talking. Okay, it's okay.
Okay.
Good evening, everyone.
Yeah.
Hi.
Hi, it was organized, and I have a
Yeah.
question. First, I'm
Yes.
Lauren. I'm a third year math student in
Okay.
Turkey, and my question is, I have recently come across several studies on PubMed
Yes.
about quantum neural networks and quantum transfer learning for early stage breast cancer detection.
Right.
So I was wondering if there is a deep analyzing system for breast cancers, and could these technologies that you have mentioned in your slides offer real contributions to neurosurgical images, and some diseases like Alzheimer or Parkinson?
Lauren,
Yes.
if you turn on your camera, we can see you also.
Yes, sure.
Yep.
Yes, sure. Just a minute. Yes, it's me.
Hi. Hi, Lauren. Yes.
Hi.
So thank you for your question. I mean, I only mentioned about neurosurgical specialties here, but there is definitely AI models and things that are currently being applied for Alzheimer's as well as Parkinson's disease. There is AI models that can now predict how early you can get Alzheimer's from imaging, from a normal brain imaging also. So there is definitely an applications already been made in Alzheimer's, and there is a lot of new technology, as you mentioned, in terms of those very latest models that are being researched, which will come to neurosurgery and these degenerative diseases. But the thing is, these models will be first applied in general things like the normal day-to-day life and text generations or predicting wind or weather, but the application will always be late in medicine because it has to go through a lot of stages of check and balances and implementing that into clinical practice will always be late because we want to protect our patients. The patients are the priority. So what will happen is it's a natural way of how these algorithms and these technology will be implemented will be that it will first be applied into general things, texts, and then you'll move on to medicine, And after it goes into medicine, then it'll come to surgery, because this is something more advanced and more very risk related specialties, where you can actually cause a lot of harm to patients if it's not applied accurately.
Yes, thank you so much. And really understand that you have mentioned checkpoints and different phases before applying to any kind of patient. So
Yes,
thank you for your answer.
no problem.
Thank you for the question, Lorraine. I encourage anyone in the audience who have question, you can ask yourself, or you can you can write it down in the chat part.
I think Mehmet Çağatay, İnce.
Oh, yes.
Okay, Çağatay, turn on your camera, please. Also, you can turn on your microphone. I have sent a request. You can turn on your microphone. Okay, good.
We cannot
See you. You turn on your microphone, but I think there's a problem with your microphone.
You can type a question if you like in the chat.
You can turn on your microphone again. Oh, no. And if you want, you can connect with your mobile phone if there is a Zoom application. Maybe it works.
Meanwhile, while Çağatay figures it out, oh, sure. Dr. Ghimire,
Yes.
like you mentioned about the ethical implications. So in your institution in King's College Hospital, how is it regulated? Is it the board of the hospital administration? Is it the multidisciplinary team of the doctor that decides whether this AI tool will be implemented in the use of in clinical practice, or is it from governmental, like what is the oversight?
Yeah, so there is, thank you for that question. So there is various levels of scrutiny or that undergoes. So there is a national level ethics application where you have to first apply for piloting or validating the AI model in the center where you work first. So local data, and then you go multi-center for validation. Once that you have to apply for ethics first. Once the ethics is approved, and then you go for this application in a very controlled setting. And once that model is then validated, you publish the results in open access areas. You have a good result coming out, and then you apply again for ethics for a pilot study that you want to do for multi-center prospective studies. Then, once you do that, ultimately, then what will happen is then you go through regulatory board within the National Health Service, which has a centralized ethics and R&D department. They will look at it, and they will look at the results. They'll look at your publications, and then only then you have an approval for a very limited environment. So what there is another part that needs to be looked at is the infrastructure. So at King's, we are lucky enough that we have a AI deployment infrastructure inbuilt within the hospital. So we can deploy some AI applications or models within that deployment structure, which then gets connected to the clinical environment. And that is something that forms a bridge between the untested models versus the real world scenario. And there are, that helps us check and balance if there is an error. And that goes through, again, through the clinicians or the surgeons or the radiologist before it's actually implemented to the patients. So there has to be a human in the loop check system before it actually goes to the patients, because then you are ultimately responsible for whatever there is output from the AI model. So that's how we do it here. It's a long, lengthy process, and that's why, as I mentioned before, it takes a while before it actually comes out. But I think that is required at this stage of where the AI is and where the models are in terms of accuracy and where the infrastructure required. But I hope and I can see that in the future this will be very smooth and more quicker once things get better with the hardwares, the infrastructure, and the ethical process.
Thank you very much for describing this rigorous process in details. Thank you very much. Can we figure out whether Chagatai is? Oh, okay. So, I have a question from Laureen. So, UNESCO recently recommended a series of rules for neurotechnology. So, it's a comment, I guess. Thank you,
Yeah, no,
Laureen.
absolutely. I mean, that is a very timely comment, and it should have come out even before, but now it has to be there, like even WHO or the UNESCO or all the other worldwide organizations should have this inbuilt in terms of how to apply these technologies into their system, not just health, but other areas, including governance or other media or things like that. So there has to be some rules that needs to be implemented.
Thank you very much. And with regards to neurosurgical education, so you mentioned the endoscopic training,
Yes.
scalp-based training. So what else? Like, for example, students, like we have a lot of students in the audience who are
Yes.
interested in the field of neurosurgery. For them, is it like, for example, in my country, we don't have the availability to work with cadavers due to our culture and etc. So do you have like AI simulated labs and for like students can learn like because surgery requires like tactile feedback. So can this AI technology substitute that tactile feedback coming from the actual cadaver training?
I mean, for neurosurgeons, it's difficult. It might be easier for other specialties, where, we require these tactile feedback. So, but there are parts of neurosurgery where you can definitely learn. For example, if you're doing a particular procedure and you're learning the steps of the procedure, and that can definitely be done with help of AI. So I mentioned about that endoscopic training. So that it can be done with nowadays. There is a couple of companies here in London who are working on building a virtual simulation with virtual reality devices where you can actually perform these procedures even if you're not in physically there. If you're connected, then you can use the virtual reality device and then go into virtually in that simulation setting and perform that procedure in the stepwise manner, and then you can know where the mistakes are made, and then you can learn that, repeat that as many times as you want. So that is something that is coming, and it's already in place somewhere. In London, we already have that. There is a company already working on it, and there's a lot of new entrepreneurs that are building this. There are models for neurosurgery that you might have seen from Upsurgeon in Europe. So these models are now applying AI into their simulation settings. Where if you have the model with you at home, you can buy that, you have it at home, and then you can connect virtually to that simulation setting. And then you can learn the procedure while you're doing it in the synthetic model that you have in hand. So that is also available now for in the market for everyone to learn. So that is something coming up. And personally, for me, I am working in the background to try and build something for low resource settings where you don't need to have a lot of hardware to learn these steps in neurosurgery. So that's something coming in the future, I suppose.
Thank you very much. Yeah, one more thing. Yes, Professor.
Mehmet Çağatay İnce will talk from his mobile phone, and we can see from his notebook.
Yeah.
Can you hear me now?
We can hear, but you can turn off your MacBook or notebook's microphone properly.
All right then.
Because it's doubled, so one of your devices should be off.
All right.
Yeah,
So
we
Now it's fine.
now it's better. Yeah.
From here.
There is an echo.
All right. Right now it should be fixed, right?
Yes.
you can talk from your mobile. No problem.
Yeah, all right. Thanks so much. So the thing I would like to ask is, sir, in your presentation, you mentioned a study about predicting the recurrence rate of pediatric gliomas. The
Yes.
thing I would like to ask is on that study is actually, is AI using only morphologic images while doing this recurrence prediction, or does AI use another type of data such as histologic or any other type of data? That's the
So
thing I would like to ask, because I thought that maybe only morphological radiologic images might not be enough to make a prediction about a recurrence rate of a glioma.
that's very true. Thank you for the question. So in that particular study that was published in New England Journal of Medicine in April, so they looked at only utilizing the images, but here the images are multiple time points. It is not just one image. And it is using images from, for example, no progression, follow-up of 4 times, like in 161 days, 200 days, or 130 days. And you're using all that time series of images and trying to see and replicate the growth of this tumor in the scan, particularly. And that's how they train the model of detecting the various progression stages. And the idea here was just to see or predict when it will recur. I understand that you're concerned that there is need for other data inputs, and that's why this is, I suppose, an early stage of that particular model. So they started with imaging, which is the easiest to have data and has a lot of information. And the problem comes if you don't have other data, then you can't really use it to train that model. So I suppose for that particular study, they must have got ethics just to use the images. It all depends on that also. So I know that, an ideal scenario would be that a model would need to learn from all the information that we can provide, but during research at this current stage, there can be lots of restrictions that you may not have the data, or you only have the imaging data, or you might just have the text data. So based on that, there are lots of studies nowadays. Very restricted data is being used to build these models, and that's why you can see that the accuracy is not as good as it can be if you provide other confounding factors into the mix. But I agree with your question.
Thank you, Dr. Ghimire, for your response. Thank you, Chagadai, for your question. Lorraine is commenting, thank you for the great presentation organizing. It was remarkable for me. And yes, we have one more raised hand. Maybe Chagadai wants to.
Yeah.
Mhm.
Thanks so much again. Sorry for not introducing myself because of the technical issues that I've faced. I'm Çağatay from İzmir, and I'm a second-year med student in here.
Okay.
So I also have another question, which was about a topic that you have mentioned in your presentation, which is again about federated learning and collaboration in AI.
Yes.
In that topic, I understood the fact that we as the new generation should build up some federated, like global type of data network in order to build up new researches about the current AI topics. The thing I would like to ask is, are there any type of database project, a global database project, which is about neurosurgery around the world, which everyone can use to collect some data to use them in their own works?
Yeah. So thank you for that question. There is some databases now available, and there are two types of databases currently. So one is open access, and another one is restricted use. And the third type is where you pay to get the data. So there are three different types of modalities how you can actually access data. In terms of open access data, we do have a lot of data available currently. So there is a big database from the United States, especially for imaging and genetic data that you can gain access from what's called the Cancer Imaging Archive, called TCIA. That has a lot of images, MRIs for gliomas, meningiomas, radiotherapy related data, including clinical data and genomic data. So that is available on permission. You can request permission from your institute and then get access to those data to build AI models independently. Similarly, in Europe, there is a new consortium that's been built for imaging, cancer imaging, especially focused on cancer for Europe. It's called EUCAM, EUCAIM, that's the spelling. So it has similar to what has been built in the States, that also has imaging data as well as clinical data, especially with gliomas as well as other cancers, that is available for application and gaining those data to train the models. There is the federated learning part is still being built, and it's not already existing, where the models can actually learn from various data sets from different institutions. So that's something that is currently under research, is not available yet, but that is what will be the future, where you can train the model, keeping your data decentralized, and rather storing it centrally, so that you can have privacy of the data, as well as then train the AI models without the data being leaked outside your servers, basically. So that's something that's coming up in the future.
Thank you so much, Madonna.
Thank you. We're reluctant to let you go because the topic is vast and very interesting. I have one last question, I promise. Like in every neurosurgeon's career, especially in young neurosurgeons, like there is a time during the surgery, like I wish I would have stopped there. I wish I could predict what is the next step, what would happen. And knowing that somewhere in another corner of the world, some surgeon had already made the same mistake. And is it possible the AI would predict your next step and would warn you before you do that to improve the surgical outcomes in the future? And if it's close, how close that future is, in your opinion?
That is a very good question for someone who's learning these techniques in neurosurgery, and ultimately, as humans, we always learn, make errors, and learn from them, and that's how it works in any specialty. Regardless of what we say, there is always a learning phase that happens, even if you are a professor, even if you are, late in your career, or if you're early. Mistakes always is something that teaches us. And the good thing about AI is that now we can simulate that in a simulation environment, and the patient does not need to be harmed during that process. And there is already AI models now built for training, especially for training only, where it can simulate where to go. It can show you the path to follow, or what are the steps you're missing during the operation. If you're doing a craniotomy, or if you're doing a resection of a tumor, what corners to look at, whether you've forgotten some steps, how to do hemostasis, or even for suturing techniques, if you missed a knot, or how to tie that knot. So there is simulation now available, especially with the virtual reality technologies, that can be done. And also there are models like the synthetic models, or high fidelity and low fidelity models, that can be built in low resource settings also, without a need for buying a lot of expensive equipment that you can build. And that's what my next focus is in the future, where I can build low fidelity models for training, for education, for various steps in neurosurgery. It might be, making some stitches, might be looking at the wound, how to identify if it's infected, or, how to, perform a particular procedure, craniotomy in a trauma setting, or there are lots of things. And then there's an example would be, for example, I used to do drilling on egg cells. So when you use an egg, you drill on the egg, and that's how you build on your drilling skills and don't go plunging into the egg. There are lots of other things like for microsurgical skills. There is a simulation where you can work on very tiny vessels and learn about your hands movements when you suture and these microsurgical micro vessels when you're doing a microsurgical anastomosis. So there is a lot of areas in neurosurgery which can be developed. Not in it doesn't have to be very expensive setting, and it can be built. And AI can help a lot in simulating that without need for an expensive simulation model also.
Thank you very much. Professor Suju, would you like to comment or any questions?
I want to thank again to Dr. Prajwal. Today, two of very interested medical faculty students made the presentation interactive with their questions. One of them is east end of Turkey. The other is the west end of Turkey, two sites of Turkey. And I am very glad because they are interested in such issues. And I want to thank everyone who joined us tonight. Thank you. I hope to see you, Prajwal. I hope to see you in İzmir. Madonna will come next week.
Okay, that's good.
And also we are waiting for you. Yep.
Thank you very much.
So much.
Thank you.
Bye-bye.
Bye-bye.
Bye.